Assalamu alaikum. In this video lecture, I will deliver the lecture on genetic disorders um, by organ system in Pakistan. Okay, in this lecture, you don't have to get that much concepts that we have had so far in all the lectures of genetics. But yeah, here also are some catch points. Like, let's start the lecture with three very important terms. One is the monogenic inheritance, one is oligogenic inheritance, and then polygenic inheritance. Okay, monogenic inheritance is beta ultra rare genetic variations with large effect, that is high penetrance. What does this mean? बेटा ये जो मोनोजेनिक इनहेरिटेंस होती है ये ऐसे जीन्स से रिलेटेड इनहेरिटेंस होती है जो कि अल्ट्रा रेयर होती है, यानी कि इसकी इनहेरिटेंस बहुत रेयरली होती है, लेकिन अगर हो जाए तो इसके बहुत लार्ज इफ़ेक्ट्स होते हैं। ठीक है, उसके कंपैरिजन में जो ओलिगोजेनिक इनहेरिटेंस होती है इट इज़ नॉट अल्ट्रा रेयर, इट इज़ रेयर बट नॉट अल्ट्रा रेयर जेनेटिक वेरिएशन। सो इसकी इनहेरिटेंस होती है, देखने को मिलती है फैमिलीज़ में, लेकिन it is not ultra rare. Okay, and the phenotypic effects are moderate. Okay, the phenotypic effects are moderate, not large effects like the monogenic. Polygenic inheritance is that inheritance when it is very much common genetic variation, but the phenotypic effects are small. Mostly the effects depend on the environment and gene interaction. That means the polygenic inheritance is that inheritance of the genes which are very much commonly being inherited, but once they are inherited, their effects, their phenotypic effects are not that large, they are very small effects, and more commonly they depend on the environment. Okay, like let's suppose beta, if your father is suffering from a diabetes, so he must be having a particular gene to develop diabetes, and if he inherits you the same gene of diabetes, if he inherits you the same gene of diabetes, so this is the polygenic inheritance because it involves multiple genes, and this inheritance is common. This inheritance is common. But once you have inherited the gene of developing diabetes from your father, you will develop diabetes or not, it is not that common. Okay, so this inheritance is very much common. Look, polygenic inheritance is common genetic variation, but the effects are small. Okay, it is not really, that means it is not really sure that once you have inherited the gene you will develop the diabetes. Okay, uh, once you have inherited the gene, then it depends on the gene and environment interaction. Okay, and if this satisfies, if there is more gene environment interaction, then there is possibility that you will be developing the diabetes. Okay, so this is the polygenic inheritance, oligogenic and monogenic inheritance in comparison. Right after that is beta concept of penetrance and expressivity. Let me explain you quickly. Yeah, penetrance is beta, actually it is referring to the probability of a gene or trait being expressed. If your parents are having a particular gene, and if they inherit you that particular gene, if they inherit you that particular gene, and after receiving that gene you will develop that disease or whatever this gene was carrying, if you develop this disease or not, what is the probability that the gene or trait you have received from your parents you will develop that feature, उसकी probability कितनी है, उसको penetrance कहते हैं. ठीक है, this is penetrance beta. Now comes the difference between the penetrance and its types, the complete penetrance and the incomplete penetrance. Okay, if let's suppose there is a parent, you know a couple with a particular gene which has to be inherited, for example, and if a couple carrying this particular gene, they have, let's suppose, 3 children. Out of these three, all these three obviously are inherited with this gene, and all of these three develop the disease. If let's suppose this gene is of a particular disease, so if a couple is carrying this gene and they inherit the gene to three of their children's, and all three children's develop the disease, This is called complete penetrance. Okay, and if let's suppose what happens if two of these three children develop the disease and this third one does not develop the disease, this is called incomplete penetrance or the reduced penetrance. Complete penetrance means the gene or genes for a trait are expressed in all the individuals with the abnormal gene. तीनों ने abnormal gene receive किया और तीनों ने express किया. This is complete penetrance. Incomplete or reduced penetrance means the genetic trait is expressed only in some but not all the individuals. Okay, so if it is expressed in two of three, it is, if it is expressed in two or two of three and not expressed in number three, this is going to be incomplete penetrance or reduced penetrance. Okay, so actually penetrance is like all or none phenomena. Okay, you will either develop the disease or you will not. Okay, if you develop the disease, you come in the category of complete penetrance. If you do not, then it is gonna be the complete penetrance. Okay, either this number 3 baby can develop the disease or cannot develop the disease. There is nothing in between. But the expressivity comes up with a different concept. Expressivity refers to variation in the phenotypic expression where an allele is penetrant. Okay, so actually expressivity refers to the range of sign and symptoms that occur in the different people with the inherited gene. Okay, let me explain you what is the concept of this expressivity. Look beta, what did I say you that if this is a gene in a couple and if they have three children and all of these three receive the gene and all of these three develop the disease, let's suppose this is said to be complete penetrance. If all these three do not develop the disease, only two develop the disease and one does not, this is said to be the incomplete penetrance, right? Then what is the concept of expressivity? Expressivity refers to that this is a couple and if they inherit, these three children are, receiving this gene and all of three developed the disease, but all of three developed the disease with some variability. This children number one, this baby number one developed the disease with more severe symptoms. This number two baby developed the disease with moderate symptoms, and this baby number three developed the disease with some less severe mild symptoms. So this is said to be the expressivity. बेटा तीनों बच्चों के अंदर कंप्लीट डिजीज एक्सप्रेशन हो तो दैट इज़ कॉल्ड कंप्लीट पेनिट्रेंस. दो बच्चे डिजीज़ को एक्सप्रेस करें, एक बच्चा ना करे, इट इज़ इनकम्प्लीट पेनिट्रेंस. और अगर तीनों एक्सप्रेस करें लेकिन वेरिएबिलिटी के साथ, एक में बहुत ज़्यादा सिम्टम, एक में कम सिम्टम, एक में मॉडरेट सिम्टम, दैट इज़ देन सेड टू बी expressivity. Okay, I hope you are clear with this concept. Yeah, okay. But then comes some genetic disorders in the cardiovascular medicine. Okay, related to cardiovascular system, there can be channelopathies, that are the disorders related to channels. There are so many channels in the heart, obviously, like sodium channels, potassium channels, chloride channels, calcium channels, that are really important for heart contractility and everything running on in the heart. Okay, so if there is some pathology with these channels, that is said to be the channelopathies. There can be cardiomyopathies. Okay, if I get back to this channelopathy, mostly what happens beta, if you develop some problem with these channels, mostly you come up with arrhythmias. Okay, you come up with arrhythmias, that is some problems with the heart, normal rhythm, normal contraction. There may be some cardiomyopathies. Okay, some genetic disorders, some mutations leading to cardiomyopathies like hypertrophic cardiomyopathy, dilated cardiomyopathies, restricted cardiomyopathies. Okay, these may be due to some genetic mutations, some genetic disorders. Okay, there may be some lipid disorders, aortopathies, related to aorta, and there may be some cardiac complications of the neuromuscular conditions, that if you develop the neuromuscular conditions and you later come up with the cardiac complications, this happens actually. We'll talk about this later part. Yeah, okay, I hope you are clear with this beta, right? So let's go a little ahead after this. Yeah, so in cardiovascular medicine, some genetic diseases, actually who needs genetic testing? If you let's suppose have some genetic disorder related to the cardiovascular system, do you really need genetic testing? There are some recommendations for genetic testing. Let me tell you, there are some class 1 category disorders of the heart, class 2A category, class 2B category, um, cardiovascular pathologies where you may need genetic testing, where you may need to confirm if there is any genetic disorder, if there is any genetic mutation that is causing this cardiovascular pathology. So for that, class 1 category includes all these pathologies of the heart. Class 2A includes all this, and class 2B includes this. Okay. If you are suffering from any of this class 1 category disorder of the heart, then uh, you are actually recommended to undergo the genetic testing and must confirm if there is genetic mutation or any genetic problem, so you have developed this disease. And this class 1 category disorders include long QT syndrome, LQTS. We'll talk about this in detail. And CPVT, that is the catecholaminergic polymorphic ventricular tachycardia, one of the tachyarrhythmias. And HCM, DCM, these are the cardiomyopathies, cardiac arrest, and sudden unexpected death cases. Okay, yeah, like sudden cardiac death. Okay, so these all are included in class 1, where you have to go for genetic testing anyways, right? And do find out if there is some problem with your genetic system, if there is some problem with your genes. And then comes some disorders in class 2A category, that is the BRS, that is the Brugada syndrome, that's the channelopathy. And then comes the ACM, arrhythmogenic cardiomyopathy. Um, yeah, and the left ventricular non-compaction, that is LVNC. In this particular category, where 1, 2, 3, okay, all these disorders are there. In this particular category, genetic testing can be useful. It is not recommended, but it can be useful. If you are suffering from Brugada syndrome, let's suppose, it is not recommended to go for genetic testing, but if you do go, then it's going to be useful. Okay, it can help you diagnose the disease. Then comes the short QT syndrome. If in this particular case, it is also not recommended, but genetic testing can be considered at least. Okay, so yeah, I hope you are better clear with this and you can memorize it. Right after this is a little concept of channelopathies that may be the reason behind arrhythmias. Okay, normally I told you beta that heart rhythm is maintained by influx and efflux of some ions like sodium, potassium, calcium, and chloride ions in the cardiac cells, that are the cardiomyocytes and the subcellular structures. There are some genetic variants that encode these channels. If there is some problem with these genes that encode these channels, so you may come up with channelopathies, you may come up with tachyarrhythmias, bradyarrhythmias, or some, and obviously subsequently there will be syncope, arrhythmic syncope. So I told you bit, if let's suppose this is a cardiomyocyte, there are some channel like sodium goes in, potassium goes out, and everything. I'm not going into the all the concepts of the action potential of the cardiomyocytes, but you need to keep in your mind there is very important and a very important role of these channels to carry the flow of ions, sodium, potassium, and all the ions. So if there is some problem with those channels, that are actually carrying sodium influx and potassium influx and all other ions, these channels are actually your proteins. These channels are actually your proteins. If there is some problem with these proteins that are your channels, so obviously, look, there is a gene that encodes this protein, and your channel is actually the protein. So if there is some problem in the gene, so your channels may not be good looking. Okay, so there must be problem with the transport of these ions, and you may come up with some conditions like tachyarrhythmias, bradyarrhythmias, and there may be the aborted cardiac arrest or sudden cardiac arrest. Sudden cardiac arrest is a worsening cardiac arrest, that you are going towards the cardiac arrest. Aborted cardiac arrest is like cardiac arrest which have been managed at a time and it is now getting better and getting back to the normal. Okay, I hope you are clear so far, beta. I hope you are clear. I have mentioned beta some channelopathies here, that may be due to some defect with the calcium current, some defect with the sodium current, or some rectifier it may be inward or delayed. So with calcium currents, the channelopathies that may be associated include Brugada syndrome. By the way, it is also associated with some defects in the sodium current. As I told you, but channelopathies are actually something. The pathology is in the channels, the transport across the channels, okay, in the cardiovascular system. So with calcium current, there may be Brugada syndrome, short QT syndrome in ECG. There may be the QT interval may be short, and there may be early repolarization of the cardiomyocytes, and there may be the Timothy syndrome, okay. And with sodium current, if there is some channelopathies, there may be the Romano-Ward syndrome or the Brugada syndrome, and there may be this some kind of conduction defects in the heart, or you may come up with the atrial fibrillation, okay. And if there is invert rectifier, you may come up with the Anderson syndrome, short QT syndrome, okay. And that is a CPVT, the catecholaminergic polymorphic ventricular tachycardia, right? So right after that, but a very important thing is the long QT syndrome. Right after this is long QT syndrome, that is the QT segment is long in the ECG, okay? You got PQRST in your ECG. If this QT segment is long, you come up with LQTS, that is the long QT syndrome. And there are multiple beta pathologies behind this, some genetic mutations which we have to discuss, and there are lots of genetic mutations. Let me show you. If I just zoom into this further, yeah, if I just zoom into this further, but there are some genetic mutations in the genes I have mentioned. Like this is the list of the genes, list number 1, list number 2, and list number 3. These are the genes with the definitive evidence, and these are the genes with the strong or moderate evidence, and these are the genes with the limited or the disputed evidence. That means these are the genes that have definitive evidence that if one of these genes get mutated, you will come up with the long QT syndrome, okay. There may be there's some mutations in the KCNQ1 gene, or KCNH2. So if there is some problem with KCNQ1, you come up with the long QT syndrome 1, and if there is some problem with the KCNH2, you come up with the long QT syndrome 2, and if there is some problem with the SCN5A, you come up with the LQT3, and there may be some problem with the CalM13, okay. So if there is mutations in one of these genes, if there is mutation in one of these genes, you have definitive evidence of developing long QT syndrome. CAC-NA1C, CSENA1C is the gene, and the TRDN is the gene. Uh, okay, so yeah, these two are a couple of genes. If one of these get mutated, there is evidence of developing LQTS, but there is moderate or strong evidence. There is not definitive evidence, remember, right? Right after this is list of another genes, that is beta like AKAP9, ANK2, and CAV3, and KCNE1. You don't have to remember all these, but you need to have a little flick of idea that this is the list of the genes that have evidence. If one of these get mutated, you may develop LQTS. That is the evidence. If one of these get mutated, you will develop LQTS, but the evidence is limited, okay, right? And then comes beta the precision medicine applied in the treatment of LQTS according to the gene mutant, okay. So if there is some problem with the KCNQ1, you can see here, if there is problem with the KCNQ1, which I told you in case of the definitive evidence. So how the precision medicine applies here, and how are you going to get rid of this KCNQ1 mediated long QT syndrome? You first need to avoid the emotional or the physical duress, okay, and you need to keep yourself on the anti-adrenergic therapy, and assist the sports participation on an individualized basis, okay. Yeah, I hope you are getting this better. If you are developing the long QT syndrome due to some defects in this particular gene, here is the precision medicine guided, guidelines for you to get rid of this properly. Avoid emotional physical duress, anti-adrenergic therapy, and anti-adrenergic therapy like nadolol, that's highly effective. and do participate in the sports on the individualized basis. Okay, and then is the beta mutation in the KCNH2 gene that obviously leads to the long QT2 syndrome that I mentioned earlier on the previous slide. So for that, precision medicine comes in the action and tells you that do treat it aggressively, but aggressively monitor the disease. Okay, and replete the potassium, avoid the sudden noises during sleep or rest, exercise caution during postpartum period, and non-selective beta blockers like the nadolol. Okay, so aggressively monitor the patient, replete the patient, replete the patient with potassium, do provide the patient with potassium, और सोते वक्त आराम करते वक्त जो पेशेंट अगर किसी को LQ-T2 है तो इस चीज़ का एहतियात करेंगे, आप सडन नॉइजेस ना करें जब वो सो रहा हो तो, एंड एक्सरसाइज कॉशन ड्यूरिंग पोस्टपार्टम पीरियड. Do allow the patient to go for certain exercises, okay, in the postpartum period, and do ask the patient to have non-selective beta blockers, especially the nadolol. And then comes the LQT3. That is due to some problems in what gene? SCNSA. So for that you have to ask the patient to take beta blockers like nadolol or propranolol, sodium channel blockers. Okay, and as is for the overlap syndromes. Okay, the recurrences actually what I mean to say. Yeah, I hope you are clear with this beta. I hope you are clear with this, right? So depending on the gene mutation, these three were the genes I mentioned earlier. If you remember that on the previous slide I told you these three are the genes: KCNQ1, KCNH2 and SCNSA. These are the genes that are having the definitive evidence of developing the long QT syndrome. So if one of these genes get mutant and you develop the specific long QT syndrome like LQT1, LQT2 or LQT3, there is a precision medicine provided management of that particular long QT syndrome. I hope you are clear with this beta. I will continue the lecture in part 2 video. Thank you so much.